at Deuk Spine Institute on November 15, 2022. Our patient travels to us from Fort Pierce, which is an hour south of us, not far. He's had back pain. For how long have you had back pain?
15 years.
15, yeah, but that's when it started, years. That's lower back pain for 15 years, off and on. Now, how long have you had leg pain?
That's been, what's on the sheet?
It's,
Just the leg?
it's really left.
He only has spot in his calf muscle.
Yeah, but still, leg symptoms.
That's been going on just a couple months.
Did something to it that was like 3 months ago.
Yeah.
All right, well, we don't know. So at least 3+ months. Now, when I examined him, his pain was in this area of his back. And I looked at his MRI, and sure enough, he had a couple of discs that were damaged. The L4-5 and the L5-S1. 2 discs. The 2 most common to get damaged, by the way. And he has a tear and a herniation at L4-5 and a tear and herniation at L5-S1. Okay? So we're going to go fix those today. We're going to use endoscopic techniques. So we're going to do a minimally invasive treatment. Dr. Deuk, I'm going to give you a little shot with some medicine, okay? That's just some numbing medicine going in. Don't get upset. Lay still. You're doing great. Beautiful. All right. So I infiltrated his skin. Needle is down. I did 6 cc's of local. And now I need to get down to where those bad discs are. And to do that, we're going to use a spinal needle. And I may have to give him a little more numbing medicine. Oh, that's not bad. I think I want to start a little lower. Okay. Where you start this surgery is very important. And the hardest disc to get to is L5-S1. It is by far the hardest. It's so hard that virtually nobody in endoscopic surgery world does it, transforaminal. They all go interlaminar. They go this way instead of this way. But over the years, I've gotten pretty good at it, and there's a way to do it properly. But not everybody knows that way. I show everybody every day. L5-S1 is the second most common disc that we treat after L4-5. Okay, good. So let's see. You want to look at the L5-S1 disc. Show them, Jordan. It is the bottom disc. Yep, show them the disc. Good. Front of the disc. Back of the disc. Yep, the foramen. Look how small that foramen is, folks. Compare it to the next one up. Look at how big that foramen is. It's all the white stuff. That's huge. And look how small that one is at L5-S1. So the L5-S1 foramen is tiny to begin with, and it's very hard to get to because you have to go at an angle because of the iliac crest. So a lot of surgeons can't do it. They don't even try. They just go and drill holes in the spine, which I don't do. Shot? Alrighty. So I'm a little bit inferior to where I need to be. Shot? Still inferior. I'm going to redirect a little bit. Shot. See if I can make this a little bit better. If you're being forced into one direction consistently, shot over and over again, then you're going to have to change your direction. Shot. So far, so good. Shot. Okay, that's a little better. And now we'll sneak around the facet. I know I make this look easy. It's not easy. Shot. It's taken many years of experience. Are you awake? I'm not happy with that one.
All right?
Shot?
He said yes, he's
Yeah, I wasn't happy with that because it's a little higher than I want to be. Shot, and I mean like higher as in to north, to rostral. When we say rostral, we mean towards the head. When we say caudal, we mean towards the tail. Of course, humans don't have a tail, but that didn't stop the early anatomists from making up these words, rostral and caudal. And every doctor uses them. You're doing great.
Fine, you're doing fine with the pushing.
Yeah, you're doing great. Well, interesting. Let's see where we are on the lateral. I don't know how happy I am with that. I don't think I'm happy, Sean. That's really the back of the disc. Let's get an AP. No pain down your leg?
Do you have any pain?
I couldn't.
Where the needle is.
Pain in his back. All right. Well, I don't think I can get more medial. I've gone as medial as I can go. And the idea at L5-S1 is to go as medial as you can. Medial is towards the midline. So I've done that because I'm right against the facet. Now I could try to go a little bit more medial now I'm right up there. I feel the facet. I'm literally on the facet joint. So I'm bumping up. I can't get around it unless I go slightly lateral and then come back and go medial again. And there it is. So this is the best I'm going to do. Wow. Sean? The question is that good enough? It's not bothering his leg, so I'm not too close to the nerve. Are you okay?
No pain down your legs, traveling down your legs? No pain.
I do want to make sure I'm in the disc. Because the trajectory is not my favorite. It's a little bit lateral, and I want to make sure we're in the disc. Are you okay? All right. Shot? How bad is that on a scale of 1 to 10? Huh?
Really heavy pressure, like a 6.
It hurts. That's where you get your back pain? Is that typically where you get your pain?
A little lower.
Is it in that area, though? Yeah. All right, well, we're definitely in the disc. You can see the tear. Show them the tear at the back of the disc. Yeah. Let's get an AP just to verify. So the needle's in the right spot. He had a 6 out of 10. It is concordant. Did you take any pain medicine today? Oh, did he get what you were saying he was going to get?
I never did.
Oh yeah, that's definitely in the disc, so we're in the right spot.
Oh, no. Well,
Pressure's
in
okay.
here, but not there.
Is there any reason you have pain and not care?
No.
Anyway, 6 over 10, concordant at L5-S1. I'm just surprised he didn't have more. All right. Yeah, pressure. But that's what you get as a pressure in your back?
Is that kind of what you get when you're at home or working?
Huh?
He has more pain
like-
when he, on a daily basis. This feels more like pressure.
He also told me in pre-op he has a lot of butt pain.
A lot of what? Butt?
Butt pain.
Mm-hmm.
And where your belt.
Yeah, I know. I remember I checked him for piriformis. He didn't have piriformis. All right, shot. So we're going to head to L4-5. Next. Shot. You okay? Oh. All right, Sean, is that where we are right there?
It's not Sarah.
Let's get an AP. Once again, the needle is in the foramen, transforaminal. And this is now L4-5, the disc above. Yeah, it looks perfect. All right, looking good. So far, so good. Are you comfy? Now, he's lost maybe a drop of blood. No pain? How bad is that on a scale of 1 to 10?
A 10. Is that where you normally get your pain?
Is that the area you get your pain?
He's very, yeah.
He's been a little bit down on my back on the left side, but it's close.
All right, thank you. Well, you get to go to sleep, and that's your job for the rest of this surgery is just to sleep. Huh? Yeah, it's concordant. All right, so just to summarize, L4-5 was more painful. It was a 10 out of 10. And it was concordant, meaning that's the area he gets his pain. L5-S1, the bottom disc, was actually only a 6 out of 10, which surprised me, but because I thought it would be worse. The 10 over 10 at 4-5 doesn't surprise me. L4-5 is the most common disc to herniate and cause pain. As a matter of fact, I don't know that I've ever done a Deuk laser disc repair on a patient where I didn't do L4-5 as part of the plan, because it's so commonly injured. It's the most commonly injured symptomatic disc in the world for lower back. You're doing great. Just take it easy. We're going to start with the L5-S1, folks. So we always start with the harder disc. Shot. You can see the guide wire is now at the front of the L5-S1 disc, passing through the needle. So we're going to remove the spinal needle and leave the guide wire. You want to be careful as you do that not to pull the guide wire out. You can actually pull the guide wire out. I almost did it there because sometimes the guide wire is bent a little bit. And if you just pull the needle out, it'll literally grab the end of the guide wire and pull it out with it. Then you'll have to start over again. And you really do need the patient awake. So you have to wait for them to wake up. That could be 10, 15 minutes. So everything's going perfect for this young man. You can see, if you've watched the earlier surgery today, that as we go in, there's no movement of the patient. And as Dr. Berndes said to me earlier, he does this anesthesia the same way. So some people, when they get, sleepy with the anesthetic, some people kind of move around and squirm a little more. Other people don't. And this patient in particular is just rock solid. Hold on. So, right? Huh?
Don't jinx us.
Oh, I'm not trying to jinx.
I was basking in the sun with
The second patient? Yeah. Yeah, our second surgery today. He was a real trooper, wasn't he?
Literally, yeah.
Without saying more. That was a good joke. A play on words. I'm sure he's chuckling in his patrol car right now. You're doing great. Sometimes, if the anesthesiologist doesn't do the job just right, the surgeon has to help with the anesthesia. You know what I mean? The old-fashioned way. You like that? She's like, I don't know.
Nervous.
Part of me wants to laugh, part of me doesn't. I think we're in. Mm-hmm. She's like, the nurse in me doesn't want to laugh. Damn surgeons are always trying to crack jokes. Okay, well, for those of you joining us, we're going to run a little video that shows you why does a disc that's has a disc bulge or a small herniation or even a large herniation, why do they cause back pain or leg pain?
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Welcome back. Okay, so where we are, we're literally down the shaft of this tube, and this tube is an endoscopic tubular retractor. Guys, I think we need a little more light down the tube. I would give it 1 click or 2 maybe. Let's see how that is. That's good.
Thank you.
Thank you, Luis. So the metal thing that you're looking through, we're at the bottom of a straw, basically, like a metal straw. And it's called the tubular retractor. It's 7 millimeters side to side on the outside. In the inside, it's about 5.8 millimeters. So the laser fiber, the glass thing, is only 1 millimeter, to give you a reference of how small it is. It's super tiny. And the camera that we're using in the endoscope is magnifying everything a lot. So to you and me, it looks big, but it's actually very small. Microscopic. So I'm going to clear up the image a little bit, sharpen it up, or I'm going to try to, I should say. That may be the best I can do. This is a high resolution camera, high definition. Okay, so it's a special kind of camera called a high definition. You can see the damage to the disc here is pretty substantial. Now, we were talking last surgery about how patients that get pain going down into their legs, that it can come from irritation of the nerve root rather than pressure on the nerve root. And the irritation comes from inflammation. The inflammation is actually coming from the herniated disc. All right, and that's what's happening here. These little blue things are herniated fragments, and they're stuck within the tear of the disc. So we're inside his L5-S1 disc right now. And his anatomy has kind of forced me a little bit lateral, but we've been able to manage to get in the disc to fix it. So I'm happy we're here getting this done. I think he's going to feel a lot better. But just, of course, if you've been with us from the discogram, you'll notice that this disc in particular is not his more painful one. The L4-5 is the more painful one. That's the next one we're going to fix. Grabber. So we'll take any questions our audience has on the surgery or any questions related to spine. These surgeries are broadcast live, so people can watch and ask questions.
So far, no current questions.
Great. Well, let's show our audience why do we do the Deuk laser disc repair? What exactly are we doing for this procedure?
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, what we're seeing here is that this L5-S1 disc has a pretty bad tear in it, and you can see it on the discogram. It's a very wide tear at the back of the L5-S1 disc. And want me to wait? He said give him a minute, I think. Right there, what you're seeing, folks, is a little bit of epidural fat. And each of those yellow glistens, those little light marks, is one fat cell. It's pretty cool. Tell me when. All right. So we shot a video on how herniated discs cause back pain. Have you played the one on what we do to fix it?
Yes, the DLDR, yes.
Excellent, excellent. All right, so we're going to keep going. We're almost done with this particular disc. This is the L5-S1. Remember, the more painful disc is the L4-5, so we're doing that one next. This damage here, to me, looks like it's been there for a long time. At least 5 years. And so what you see is a lot of scar tissue within the annulus, within the tear.
How old is this there? 17 years, right? It's 17 years old. Injury?
Grabber? Oh, parkour.
I bet it's.
That's this injury right here. This looks like it was over 10 years old, seriously.
But he didn't tell anyone because he was afraid.
Yeah, I think he injured 5-1. All these pieces of blue I'm taking out.
He's like, I don't know, I didn't tell anyone. It was
No, he didn't have a fracture, but he broke his disc.
like
Yeah, that's what I'm dealing with right here. Now maybe the 4-5 is more recent. You know?
a lifting injury.
Yeah, but he has 2 discs. This one has, see the blue stuff I'm pulling right now? It's fluffy. That's newer. But all that whitish stuff down there is all old. Like many years old. This right here, this piece is kind of a mix of old and new. Is he doing all right? Yep. All right. Just about done. I'll wipe.
We have a question.
Sure.
This comes from John Ski on YouTube.
Uh-huh.
And they ask, will Dr. Deuk operate on a patient who has had surgery before?
Yeah. The answer is 100% yes. Dr. Deuk, which is me, by the way, and Deuk Spine, we don't turn anybody away with back or neck pain. And we operate on people that we can fix. with surgery. So what that means is I'm not going to do surgery on someone just because they want surgery. I'm going to do surgery on someone because they need surgery. And the answer is, if they've had surgery before and there's a problem, a surgery problem, that they will get better with my treatment, that's the best treatment for the patient, I'm going to recommend it and I'm going to do it. Yeah, a lot of our patients that you see here, for example, we had our second surgery for the day, who happened to be, I can't really tell you, but anyway, he had a microdiscectomy before, and he never got better with his back pain. He's had pain for years, and he came to me and we fixed him. I think his pain is gone now. So, but the point is, we don't turn people away because they've had surgery elsewhere. If they have a problem I can fix, I'll fix it. All right, I think we're done here. We're going to move on to the next disc.
Lights on, please.
So yes, we operate on people who've had any kind of surgery. I don't care if they've had surgery before. I don't hold that against them. It makes my job harder, that's for sure. But there's not many surgeons out there that will take a patient who's had surgery in the past. So I know those people who are suffering that could use my help. They may not be able to get help anywhere else. So I want to make sure I help them. That's why I went into medicine anyway, to help people. So I know it's a harder surgery and it's a lot of difficult scar tissue and screws and rods and sometimes bone graft and other issues. But I enjoy the challenge. And there's nothing I'd rather do with my time than to help people get out of pain. So, all right, done with L5-S1. We're going to go to L4-5 next. I have a feeling we're going to see newer herniation at L4-5. Oh, I'm making a mess over here. I need a towel on the floor, please. For some reason, the irrigation is going around my bag. We use plastic bags to catch the irrigation. Sometimes, despite our best efforts, we get some water on the floor. Somehow I managed to get a lot of water on the floor. So far, surgery is going well for this patient. Any other questions from our audience at this time?
No current questions, but we do have a comment from JFM on YouTube, and they commented, "Wow, this is intense."
Yeah, it's pretty cool. First time I saw this surgery being done, the endoscopic approach in the lower back, I couldn't believe it. I literally almost fell on the ground because everything that I had learned in training in my neurosurgery spine training residency was open surgery. And this type of technology was not mainstream. And the first time I saw it, I thought, there's no way this is going to work. And then the patient did well. All right. They did really well. And so I started doing the procedure myself. I bought the equipment, started doing them because I believed that it had potential. That was 16 years ago. And nowadays, you know, it's part of our daily routine, so we don't really think about it. Thank you. But I still remember how I felt the first time I saw this. You see, this approach was developed not by a neurosurgeon. I believe it was developed by an orthopedic surgeon. And I'm a trained neurosurgeon, so neurosurgeons are kind of weird. They like to pretend they know everything, and they don't like to admit that an orthopedic surgeon might have figured something out they don't know. So there's been a couple of orthopedic surgeon pioneers in this field of endoscopic spine surgery. They were actually the first pioneers, not neurosurgeons. So I kind of get the feeling that the neurosurgeons don't like to teach this technology to their own. for a variety of reasons, but one of them may be because it was very firstly done by an orthopedic. That is a well-used hammer, huh? Look at all that. We've had this hammer for years. That was a good value right there, good investment. All right. Thanks for the comment. But that's why we broadcast surgery live, so you all can watch and see what we do. Yep, and ask questions, of course. Let me tell you, when you go and do training as a surgeon, the reality is there's far more residents that want to learn the technique than there is space available to learn it. And what I mean by is, when you're doing spine surgery, you have a surgeon on one side of the patient, you have the resident that's assisting on the other side, and everybody else is kind of trying to see what's going on. But typically you're working in a wound that's deep, so you're like this looking down. Nobody else can see what's happening. So if you're the second level resident or third level in the room, you're not seeing anything. So what I decided to do here for you all was to put a camera in the ceiling. And of course a camera here that I could show you, and then an x-ray machine and a microscope. So everything that I see, I share with you. We even have a camera we put on my head when we do a fusion. So that way you all can share in the experience that we're doing. Laser. And it makes it more informative to the observers. So it's even better actually than what I had being trained as a resident, because the truth is your first year as a resident, you're not even in the operating room. Second year, you are called to the operating room to close the wound. It's the ultimate insult. I never did that to the younger residents, but some of these senior residents, they just don't care, and their feeling is they did it, they were abused when they were a junior resident, so they're going to abuse a junior resident. So we would be busting our hump on the floor, taking care of patients, writing orders, collecting labs, getting results, moving people to the CAT scanner for emergency CAT scans, etc. We'd be killing ourselves all night, basically. And we get a phone call to the operating room, and it would be, Dr. Giovanni wants you to come close the wound. I'm like, what? Basically, he was done doing the hard part of the surgery and wanted you to come and put the sutures in. So, of course, we didn't have a choice. Laser. We had to do it because that's part of your training. There's a hierarchy, and you got to do what you're told to do. And you got to do it with a smile on your face. So for years, your first 2 junior years in neurosurgery training, we're called to do all the work that nobody else wants to do on top of our work. Of course, you take it and you do it, and you're never appreciated for doing it, never. You just consider it part of the job and part of that path, you know, to go from dirt on the bottom of your shoe to a full-fledged neurosurgeon. It's a very abusive system, at least it used to be. I'm not sure what it's like elsewhere, but there were some programs that were not so abusive, but the non-abusive programs for training were also not really the good ones. So the truth is that if you want to be a great neurosurgeon, those 7 years you're working 110 hours to 120 hours every week. Literally working, not sleeping, not resting. That is time on your feet operating and taking care of patients. Now, most people work a 40-hour work week. We worked a 110-hour work week. Basically, we didn't sleep much. And the amount of knowledge and information you gain taking care of those patients is, there's nothing like it in the world. It's worked for 100 years. And it's probably the best system available for teaching people a lot of concentrated information in a short period of time. But that's what I went through. So I spent my first few years coming in the operating room closing wounds. And when you're closing a wound, it's just you. So you get a great view of what they did. And you can kind of poke around a little bit and see what they did. Where they put the screws, how they tighten the rods, you know, what trajectory they use. So you kind of learn a little bit by just being there closing. And then the other thing you do as a junior resident neurosurgeon is you get to help assist the neurosurgeons, that the faculty that nobody really likes. So the really mean ones, well, the chief resident doesn't want to operate with them. They want to operate with the ones that are nice and fun. And it's funny how it works, because the faculty neurosurgeons, they want the best resident operating with them. So they want to smooch up a little bit to the chief resident, the highest resident. That way the chief resident will want to be in their room and help them. So it's kind of an interesting dynamic. But let's just say, as a junior resident, your second year and third year in training, those are second and third out of 7 years, you're going to be getting into the operating rooms and doing things that nobody wants to do. So you kind of learn how to do shunts, you learn how to close wounds, you learn how to do biopsies, and you learn how to operate with surgeons that are very difficult to get along with. I have a lot of YouTube videos of my surgeries, and sometimes when my staff don't do their job right, I get on them. And they understand. I'm getting on them because I care about the patient. I want the patient to do well. But I have some of my older videos, I have people criticizing me for being hard on my staff. And it's like they have no idea what it's really like. All right, so far, what am I seeing here? This is the L4-5. I'm actually surprised because I'm seeing a combination of the blue stuff, the really dark blue, is the newer stuff, and the white stuff here is all scar tissue from old injury. So this is a hybrid disc where we have old and new mixed together. So this is clearly an interesting case where, look at that, right there. See that blue right there? That's new, like within a year or two. But the white stuff with the calcium deposits is old. So this disc is definitely under pressure. You can see as I'm removing parts of it, you're starting to see parts billow out, like billow towards us, like they're under pressure, trying to escape. And, you know, when things are under pressure, where do they go? No one? Path of least resistance. Oh my God. High five. High five. Psst. We have somebody with a brain who's awake. I love it. I was testing you guys. Path of least resistance. So the path of least resistance is into the tube, right? Because anywhere else you've got tissue around you pushing back on you. It's kind of like, you know, a crowd of people at a concert squeezing each other under pressure, and then there's a, look at that. See that just pop out there? This is the path of least resistance, right where we are. So it's kind of nice. All the herniations pop back to us, and we just zap them out with the laser. This is the most incredible surgery in the world. It really is. People don't understand that yet. They will. This is going to be done everywhere in the world someday for back pain and neck pain, for herniated discs. There's not going to be any more fusions done. There's not going to be any more artificial discs done. There's absolutely no need for them. This surgery can replace all of those cases. There still will be some fusion done for tumors that destroy the spine's integrity or fractures that compromise the stability. But all the degenerative surgeries that are done every year, the millions that are done around the world, will be done with this surgery. All right, here's a newer herniation. There's still some scar tissue in it, a little bit, and calcium. You see that? The gold. All right, any questions?
There are no current questions.
No questions. Do we lose the European viewers?
I hope not.
Well, they're 6 hours ahead.
This is
And
true. It
Right
is.
now it's 4, so it's 10:30 at night in Europe.
Yeah.
I think we lost a lot of the Europeans. That's all right.
It's all good.
We have about 5 minutes left.
Dr. Berndes, for you, I will do it in 5 minutes. Will you be happy with me?
Just curious. Medication.
I know, I'm kidding. 5 minutes. I think 5 minutes would be perfect.
He's doing very well.
Of course he is. He's got the best anesthesiologist in the world. All right, so if you have questions, feel free to ask. Type them up, we'll answer them. That said, we're just about done. This is almost in the surface, the outer surface of the disc. And you can see some annular fibers there. That's what they look like. They crisscross. But you can see all the damage done down there and how there's still herniation there. Okay, I'm going to try to grab some of that herniation out just to facilitate and expedite. So at the end of this surgery, I'll come and answer your questions for you, face to face, and that will be a wrap. You're switching irrigation? All right, not a problem. Laser? What? So what kind of shortages are we still dealing with?
They're actually lidocaine, so we can get a lot of the little Tylenol and Tylenol vials that you can hear about now.
That tear's running off the side there.
Our things are getting better. Anything with epi is terrible still.
Epi is what?
Anything with epinephrine is still difficult.
Really?
So any lidos, markings,
Still a problem? Interesting.
it's getting better. Everything's getting better. Clinda's getting better now.
Clinda I don't care so much about. I mean, he does? What does Patel use Clinda for?
Anytime
Oh, spinal cord stim?
spinal cord, well, anytime he uses an antibiotic, so hypos, stimulators, discograms, any of those.
All right.
But he's kind of switched over everything to Ansep with the shortage.
Yeah.
So now we have all this Clinda and we're not really using it.
Uh-oh.
Yeah, which is, no, it's fine. It's good till like 2027.
Everyone take some Clinda home with you?
No, yeah, keep it here. I don't want to have to find it again.
I'm joking.
Oh, your lidocaine gel either stopped making, so
Yeah, we deal with shortages in the medical field of pharmaceuticals. The pharmaceutical companies have resorted to concocting and creating fake shortages so they could raise the price of supplies and actually charge 2, 3, 4, 10 times what they normally do and get paid it.
Yeah, that was my order, but I received it.
How many remember Enron? The Enron days. Huh? No. Enron was the 80s, 90s. When they were faking the power outages for the California. All right, we got 2 minutes left. We'll be done. This is all fat. That's why the irrigation is milky. This tear is an interesting geometry, you know, if you look at it. It's not like every other tear. Every tear is different. This one is partially healed. It's not completely healed, but it's partially. And it'll never completely heal without the surgery. Looking good. The laser is such a precise, beautiful, powerful tool. I love it. It's the best surgical instrument you can use in endoscopic surgery. There's nothing better. All right, we're pretty much done. I just want to zap a little more of this and we'll be done. They say that the surgeons who played a lot of video games when they were younger tend to be better surgeons. So I'm sure my son is going to be one of the best in the world.
What he like to play?
Is he listening? Does he still have his AirPods on?
He is not.
Shame on him.
What he play?
Huh?
Like a shooting games or racing or?
Oh, he's working on a paper.
No, but what he playing like a video?
Oh, what does he play? He plays Clash of Clans.
Okay.
You know, that kind of stuff. All right, let's see here.
I just woke up. What
Let
happened?
me do just this tiny bit more. Luis,
I'm sorry, one more?
tiny bit, tiny bit. I thought I got it all. What'd you say, Henry?
I said I just woke up.
Oh, welcome, RS. Do you have your data? I'm so excited to see it. Arias is working on an incredible project comparing the Deuk laser disc repair, what we're doing right now, cervical though, with ACDF, and looking at the use and prescribing of narcotic painkillers, opioid painkillers after surgery. And Dr. Berndes is actually helping us with this project. And so I'm pretty excited to see what the data shows. I suspect the DLDR patients are going to have less narcotics prescribed after surgery. So we have to send our data off to a statistician who's going to do an analysis. All right, I'm pretty much done here. Looking good. Now, let's see if we can find the nerve root somewhere in that fat over there. Luis, let me get this little area right here. Let me have that laser again. I'm sorry. I tricked you. Ten seconds. Done.
Lights on, please.
Herniation is gone. Annular tear is debrided. I need irrigation. And hopefully our patient's pain and symptoms are gone. You know, to do a successful job with the patient eliminating their symptoms, there's two things that have to happen. One, I have to make the right diagnosis as to the source of their pain. And two, I have to do a good surgery. So surgery is usually not an issue. The diagnosis is hard. We are done. Let's show everybody the incision. And then Henry, if you would, maybe run a quick video till I get over to the conference room. By the way, for those of you watching today, our first 3 patients are already gone home. These are all outpatient surgeries. Our last patient had a 4 level. This patient had 2. The last patient's already gone, right? Yeah, he was ready to go when I came in here. He was looking good. Still a little wobbly from the anesthesia, but he looked great. All right. There it is, folks. You see it?
Yes, we do.
You know what I say? Peace. Good job, everyone, today. I'm very happy. Everything went really well. Thank you all for your help. Dr. Berndes, great job. And thank you all for watching. I'll come and answer your questions. You want to cut to video? Henry? Did we lose Henry? It's Dr. Ari Deuk at the Deuk Spine Institute here in Florida with one of my patients who had the Deuk laser disc repair for a back injury, and it was around 6 to 8 weeks ago. And you're back for a checkup. How you feeling today?
I feel wonderful. I feel great. I feel fantastic. I mean, this is the man. He's the man.
Well, thank
And I
you.
came in with a lot of pain. I couldn't believe it. And now I'm virtually pain-free. It's unbelievable.
How long did you have your back pain? How did that start?
Oh God, that happened many years ago at work, at least 20 plus years. And I had other surgeries in the past, and they really didn't help. And this last one, it just got so bad that I had to do something. So luckily, through the grace of God, I came here, and
Amen.
yeah, and I'm A1 now.
Awesome. So you had your surgery, you've been doing therapy. Would you say the pain you had in your back before surgery is still there, or is it gone?
Oh, it's gone. It's gone. I have little twinges now, but they're muscular, and which is fine. That's going to go away over time. But my God, what a relief! I'm ready to get back out there and do all the things I used to do, man. It's kind of exciting. It's kind of fun.
Well, it's important that people understand too, when you have 20 years of chronic debilitating back pain, what happens is the muscles in your back shrivel up and atrophy because you're really not active anymore because it hurts too much. So, you know, we can fix the spine pain, but it's going to take time to rehabilitate the muscles and get them back to normal. So I'm glad we're touching on that. So what does your life look like now that we've gotten rid of your back and leg pain?
Well, yeah, I'm going to go back to what I've always done and what I've always enjoyed doing, which is my automotive hobby. And I'm really looking forward to being able to actually lift things again and getting the contorted angles that I used to get working under cars and stuff. It's just gonna be nice. Quality of life is it's
Not too soon with any of that lifting engines.
all right,
and
all right,
contorting your
all right,
body.
yeah, all right. But I have, all kidding aside, I have noticed over the years I developed a way to walk, almost a crab walk kind of thing, and I got used to it, and I got, well, that's the way it's going to be. I don't have that now. I mean, it took a little while because it was some pain trying to get the muscles to come back. But my God, you just stick with it. If you got to get it done, stick with it, because you're going to get better. You're going to get better.
Well,
Yeah.
Congratulations. Is there anything you want to say to wrap things up to your audience?
He's the man. Come see this guy.
All right, congratulations.
Thank you, doctor.
You are
God
welcome,
bless.
sir. God bless you. Hi, Dr. Dumazing. We're just wrapping up our surgery, and everything went very well. The patient had herniated disc, L4-5, L5-S1. When I got into the disc with the endoscope, I could clearly see that these injuries to the disc were older. They've been around for a while, but there were some fresher, newer components to it. That was the darker blue. But there was a lot of old scar tissue and calcium. So clearly old injuries, I would say probably 5 to 10 years. Possibly even a little bit longer. Could have been a little more than 10 years on some of them in some of the areas. But surgery went perfect. He came to us with back pain into his buttock and left side, and I think he's going to do quite well. All right, let's take the questions.
All right, this first question comes from JFM on YouTube, and they asked, I have had 7 operations in the last 2 years trying to get my L5 to S1 to heal up because I can't get their hardware to hold any movement. So my doctor decided to use a drug named Forteo. It's supposed to help bone growth. Have you used this drug before, and how did it go?
Okay, so you're asking about Forteo. Forteo is used for osteoporosis, to strengthen bones and make them stronger, to build calcium in the bone. I don't prescribe Forteo. It's prescribed by doctors that are called endocrinologists primarily, and it is a good drug for building up bone, but it takes years to build your bone up. I don't think that's the problem. I think you have something else going on with your hardware. typically if the hardware has failed, then the doctor didn't do the surgery right. And so I would bet that there's a problem with the way the surgery was done. And there's like 5 things that they could do wrong. One, they're not using load sharing cage in the in your body space. So they may not have put a proper cage, like they may not have put a cage at all. They may not have put big enough cage so it shares the load of the weight of your spine. They may not have put big enough screws. They may not have put the screws long enough or in the right place. Or you could have fractured screws or rods. There could also be an infection in the disc space that would cause them not to heal properly. So I'm not sure what's going on, my friend, but I don't think Forteo is the answer. Forteo is your doctor's way of getting rid of you and having you believe in the yellow brick road and go down the yellow brick road. Just get away from him or her, whoever did your surgery, so you're not bothering them. The reality is that they didn't do the surgery right, and you need to have your back looked at by a real expert to figure out what's wrong. I would be happy to do that for you. We offer a free MRI review. So if you have an MRI after your surgery, it's recent, I'll be happy to look at it for free. Just go to our website and fill out the form. Thank you. Next.
All right. Next question comes from Will Rivera on YouTube. And they said, "Hey, Dr. Deuk, how are you? Thank you for the amazing."
Hi, Will Rivera.
How are you? Thank you for the amazing, your amazing vids and information. I have an L5-S1 disc issue, and I'm seeking to get ELD surgery. Can you tell me your thoughts on ELD? The pain runs down my left leg and goes all the way down to my toes. Can't sit and can only stand for short periods, and that's when not medicated.
Okay, great. Well, thanks for coming and asking. So I guess we'll make the assumption that the L5-S1 disc problem, herniation, bulge, whatever it is, stenosis, is the cause of your symptoms. So assuming that the L5-S1 disc is the cause of your symptoms, then surgery is definitely necessary. And there's many different types of surgery. The best is what I do. It's the endoscopic Deuk laser disc repair. And we go through the foramen, the neuroforamen where the nerve comes out. The nerve is getting pinched right there by a herniation in the back of the disc. So I come in right under the nerve root and I use a laser to remove the herniation and get it unpinched. That is your best option. I don't know where you're going for your surgery, but I would be very cautious because a lot of other surgeons are going to start taking parts of your spine out, the normal parts, just to get down to the herniation. I don't know who's doing your surgery or what technique they're using, but if it's me, it's the best you can do. Let me just put it to you that way. I'm just being honest. Otherwise, I don't know what the surgeon's going to do, and there's so many bad surgeries out there. As you see, the guy before you who just asked the question had 7 surgeries on his back, 7 or 9, either 7 or 9, but you should never have more than 1 surgery. I mean, 1% of the patients will have a problem with where you operate and they get a second surgery. But when you have 7 or 8 surgeries on your back in that area, the surgeon is not doing the right surgery. So you really need a good surgeon and the right diagnosis.
Next question comes from Garmina on YouTube.
Hi, Garmina.
And they asked, yeah, if you recommended me to have surgery with you on my L4-5, the S1. If I have surgery with you, would the disc ever get damaged again?
Hi, Garmina. So you're asking if you do have surgery like the one I just did, the Deuk laser disc repair at L4-5-5-1, will the disc ever get damaged again? So let's pretend for a moment you have the surgery, and then you follow my instructions, and 1 year later the disc is completely healed. Okay? Then you jump off of a water slide and you go 20 feet in the air and you land on your butt. Do you think the disc should be damaged again in that scenario? Yes or no? If your answer is no, it shouldn't be damaged, then you are definitely not in touch with reality. And you're right, do not come to me for surgery. I don't like operating on people who are not in touch with reality. But if your expectations are reasonable and you're a reasonably intelligent person, then you'll understand that when I fix your disc, they will be fixed permanently unless you re-damage them. Can you re-damage the disc? Absolutely. Jump off a roller coaster, you'll damage your disc. Jump off a cliff, you'll damage your disc. Get into a car accident, you'll damage your disc. I mean, the list goes on and on and on. So after I fix your disc, they will heal normally. As long as you're careful and you don't damage your disc yourself, they will never be damaged the rest of your life. They won't be a problem. So hopefully that helps.
And that is it.
All right, I hope you enjoyed the broadcast. And we're done for today. We've done 4 surgeries. We broadcasted 3. On Thursday, we'll be back. That's in 2 days. And we have more surgeries on Thursday. Great job, Henry and the team. I want to applaud my team today. They did an awesome job. Thank you.